So, good morning, ladies and gentlemen. Welcome to the International Symposium of Intensive Care and Emergency Medicine in Brussels. With its 44th edition, EasyChem has become one of the, I would say, oldest critical care meetings all over the world. Well, maybe not old, I would say maybe wise and mature, like our discipline, which has tremendously evolved over the years. And as EasyChem is getting old, so do I, because I cannot read anymore the notes I put on my presentation mode, but whatever, I will try to do my best to give you a nice opening. What we can do to keep us younger, we can try to inhibit our interleukin-11 signaling, as it's been nicely presented in this study in Nature Medicine, but I have another way to keep us young. Basically, what we can do is keep you running all over the place. You will find a lot, hundreds of presentation, lecture, hands-on. You have just to decide the right one to pick up. And don't forget that when you find the perfect session, there will be another one which is starting, equally fascinating. So I hope that you have a great scientific program to enjoy over the next days. How to do not to get lost? Well, you can download your application now. You can easily access the scientific program. You can prepare your personal agenda. You can decide which part of the building to go, see the floor plan, and of course keep updated on the latest news and updates. And this is just to remind you how our Congress is organized. You see on the right the plan of the building. And you see in the middle of the slide our exhibition area. Please visit and meet our exhibitors. And don't forget that we have in the exhibition areas 5 demo boxes where sessions will be hosted and where posters will be presented. For the first time, we have decided not to keep the posters on Tuesday evening, but poster presenters can present their research from Tuesday to Thursday with dedicated session. Of course, you can also enjoy to meet people, create networking, of course, not during the timetable of the Congress. That will be outside the Congress, but you can, of course, visit. We are in the heart of Brussels, and you can, as you see here, taste some of our local specialties. These are Belgian beers, but there are many, many others you can enjoy over the next days. And because we like to provide you the best entertainment, besides the scientific program, don't forget that we have a social event on Thursday evening at the balcony. It's very close to the Congress venue. There are some places remaining, so please don't hesitate to join us also for this activity. So you know that we play with numbers every year, so this year is a number 44. So I found that 44 is a number representing achievement, hard work, and deserved rewards for the future. You know that in 44 before Christ, Julius Caesar was murdered. And the number 44 is the special number of the multiple world champion in F1, Lewis Hamilton. Of course, June 44 reminds us the D-Day when Allies arrived in the northern France and started to get Europe free from the Nazi. And Barack Obama, one of the most influential people in the political life, has been the 44th president. Now I know what you are thinking. I will not use the same example next year for the number 45. Don't worry. So EasyChem is not only a 4-day meeting. We started over the weekend. These are our 6 present-home courses. For the first time, we have hosted an artificial intelligence and EG in the ICU patients. And we just finished, and you will hear the report from Giuseppe, Yelena, this fantastic, really round table about disorder of consciousness. We have brought scientists with different backgrounds in Brussels, and we have discussed about this very relevant topic over the weekend. Of course, EasyChem is not only science, entertainment, but is surely preparation and professionalism. And I need to thank this fantastic team, Pierre-Yves, Colette, Ina, Aldo, Estelle, and Karen, perfectly managed by Veronique de Vlamings. Great team. Thanks for all the things that you have done to make this happen. And of course, I have to thank our scientific committee and the local committee for their great contribution to make a so great program. Thanks again for everything you have done. Now, together with Professor Jean-Louis Vincent, we'd like to remind you this is a short saying, which is, we care intensively at EasyChem. We care intensively for the education, for this cutting-edge research. We want to advance medical knowledge and train the next generation of intensivists. We also care about our patients because we want to improve their outcome. We want to enhance the therapies. We want to provide personalized critical care intervention. We care about the families because we recognize their essential role in this ICU journey. We recognize the suffering they're going through. We want to ensure compassionate communication. And of course, we care for our community because we would like to help to build network, collaboration, innovation, and of course, favor advances in intensive care medicine. I realized that our work has become complicated. ICU healthcare providers have to deal with very complicated patients, multiple organ failure, but we also need to stay updated on this overwhelming volume of literature that is published every day. So being an ICU healthcare provider today means integrating advanced physiology knowledge, internal medicine, organ dysfunction, pharmacology to optimize care and decision. This is a great challenge. But the great challenge I see is that ICU is, of course, just a part of the journey of the patient, which starts sometimes in the emergency department, in the pre-hospital phase, and go through the ICU wards, before and after the ICU, to the rehabilitation, to the community reintegration. And so on one side, this means that we need to have an holistic and multidisciplinary approach to better integrate what we are doing in this long journey. And on the other side, this is again a challenge. This will expand the role of the ICU team, which will need to go outside the wall of the intensive care and then collaborate with our colleagues, maybe discuss about giving advising, collaborating for the most severe patients and high-risk patients, maybe give guidance how to make surveillance in this case, and also be integrated in the post-ICU early follow-up and ensure a smoother transition from the ICU to the ward. And of course, the advances in technology and monitoring will help us. Maybe in the future, when the patients arrive at the hospital, we never know what happened before. Just taking the parameters from these kind of watches, vital signs, we'll know exactly what happened. We can provide even more advanced technology outside the hospital and the ICU. Maybe with these specific ventilators, we can even have drones driving miniaturized ECMO on site. And of course, we have heard since a few years the evolution of artificial intelligence or augmented intelligence, we say, is helping us to better clustering our patients and provide personalized medicine. And this will, of course, improve the evolution of telemedicine, where the collaboration of different experts will improve the quality of medical decision across centers. But also, together with all these challenges, we need to, of course, consider the environment in the ICU. We should be more patient-centered. I like this paper from John Fraser Group, which has highlighted, which is very important in the environment for the patients in the ICU, considering the sound, the light, the temperature, the smell, all these things that are very relevant to provide the best comfort for families and visitors. If you have the time, I put the link on the YouTube video explaining how these people have conceived, as discussed, as designed the ICU, the new ICU, which should be patient-centered. And of course, behind logistics, we can even put more humanization, maybe in the future, including, indoor plants, or as we've done in our department, promoting zootherapy. This is a picture of myself with Yuki, a dog we have bought for the ICU, which comes every weekend, thanks to the help of one of our ICU nurse, Claire, which brings Yuki to the patient bed, and we hope that this will provide some comfort in this very difficult moment for patients and for families. And maybe in the future, even virtual reality could be helpful, because this technology can not only provide relaxation and maybe improve the tolerance on several procedures, but be used in the rehabilitation phase and even provide some help for post-traumatic stress disorders. I talked about the challenges, I talked about technologies, about logistics, but I think that as a community, we also have to stay strong to protect the integrity, the freedom, but also the transparency in medical research. And we need to underline that the distribution of resources should be based on science, because this will help many ongoing projects and researchers to achieve what they are trying to evaluate. And also as a community, we need to stand strong against mystification of medical research from politicians who should acknowledge their incompetency in talking and discuss about healthcare. And of course, it's a personal message, I would say, and as a community, of course, we need to raise our voice and hope that in the future there will be more peace in the world for all the people that are suffering now of wars and all our colleagues that are working now in these very complicated moments in these areas. I really hope that peace will come very soon. Another important message, I think as a community we must honor the extraordinary contribution of pioneers in the ICU, people that have been great mentors like Professor Luciano Gattinoni, an exceptional scientist, a person with, I would say, a unique personality that has inspired, influenced, I think, all of us, who have left a legacy, a great legacy of loyalty, of collaboration, of innovation, which we must continue to uphold in the years to come. Of course, EasyChem exists also thanks to our, the support from the industry, and we really need to thank and acknowledge the help of our platinum sponsors, the gold sponsors, and our silver sponsors, and all the other people that have contributed, not only economically, but also with some input to improve the quality of our program. The last word will be for our other activities. EasyChem, of course, is the meeting, the 4-day meeting in March that you know, but there are other activities that we organize over the year. I'll remind you the Euro-Neuro Conference 2025, which will be organized in Paris, thanks to the help of our colleagues. And we're also launching for the first time the EasyCare meeting, which is a dedicated international symposium on cardiovascular care, which will be held by my two colleagues, Vincent Labbé and Filippo Annoni. That will be in September. And of course, our course on echocardiography in November. We have early December this great course on applied physiology for the ICU patients, mainly but not only cardiovascular respiratory, and our December meeting on challenges and innovations in emergency medicine. This is our website. Please check all these activities and join us, of course, if you like them. I think this is the time to leave now the podium to the two chairpersons, to Haley and Jan, who will introduce the topics for this opening session. I can just thank you again for being here in Brussels and enjoy the meeting.
Thank you so much, Fabio, for kicking us off so well. We will now have a series of very interesting talks that I think will go very nicely with your description of how we have a lot to learn. Welcome, everybody. I'm Haley Gershengorn. I come to you from the University of Miami in Florida in the US, although that's hard to say these days. And I appreciate all of your support for the importance of truth in science coming out of the US as well. And with that, I will turn this over to my co-moderator to introduce himself and our first speaker.
Thank you very much, Haley. Good morning, everybody. I'm Jan de Waal, intensivist based in Ghent, Belgium. It's a pleasure and an honor to be here this morning. We have, I think, a great set of presentations, and I would like immediately invite Yelena Bodien from Nashville and Giuseppe Citerio from Monza, Italy, to present the report of the Roundtable Conference. You know, this is an annual roundtable that is being held prior to this meeting. The topic this year was consciousness disorders in the ICU.
Thank you very much for your kind introduction. And we are going to report here the result and what we discussed in the last few days about disorder of consciousness in a roundtable in Brussels. As you can see, we met 3 days in Brussels, and this is not working. This is the 35th edition of the Roundtable in Brussels, and the third one dealing with neuro topics, because we had a very old consensus conference about brain injury, another one on neuroprotection, and the last one on disorder of consciousness. And we were very happy to have some neuro topic here, because I think it's transversal. I tried to convince you that all of us will be involved in a discussion on this patient with disorder of consciousness. We had 18 participants coming from very different academic background. We have intensivists, for sure. We have neurologists, electrophysiologists. We have some basic science, physiology. We have neuroscientists and people dealing also with rehabilitation. So we cover the full spectrum of a disease, not only the first part of a disease, and also we discuss about mechanism of consciousness. I would like to intrigue you describing why it's important for you and what are disorders of consciousness. We usually visit the patient bedside looking at motor sign, and we define a patient that is not awake in a coma, or a patient awake, or a different status of changes of his or her performances. But we test mainly the patient with motor function. We are not so able at the bedside to look at cognitive function. And we discovered recently a lot of patients with cognitive function maintained, but no motor response. Is what is in pink in this cartoon is so-called cognitive motor dissociation. And I think most of you doesn't know really what does it mean. At the bedside, we visit the patient, we take a neuro exam, and we say the patient is in a coma, but probably we are losing all these nuance. And we decide with Fabio to have this conference because we know that DOC, disorder of consciousness, are frequent in the intensive care unit. And we want to underline they represent a continuum, not only coma or not coma status, and it's very difficult sometimes to make the diagnosis. And we wanted also to warn the community about the potential of cognitive motor dissociation at the bedside. An expert, the group of experts that meet, was so humble to say that we are uncertain about the prognostication in the early phase. And it could be a risk because also the next speaker will talk about withholding and withdrawal sustained therapy. Could be a risk for patients that not deserve the withdrawal of care to be exposed to this action that brings usually to death of a patient. We also wanted to hear the voice of the stakeholder, and with the support of the Neurocritical Care Society and the Curing Coma campaign, we hear the voices of survivors, patients and families. And we hear from the patient and family the voice that probably we miss up the diagnosis, we make error in diagnosis and in prognosis in the early phase. In almost all the cases we had presented here, and the family want to have from us some support, understanding the path, understanding the probably outcome of a patient reasonably, and not giving hope they are not present, or giving a pessimistic view when some hope is present. So they need to have better communication, better interaction with us. And so the aims of the roundtable were to demystify DOC, improve our understanding, discussing about our understanding of DOC diagnosis, look about the intervention we have at the bedside today, and how to promote accuracy for prognostication. I will give you some caveat because the result that Yelena will present shortly is not a consensus. We didn't vote, we didn't make a Delphi, we didn't make a search of the literature. It was a group of experts that met and decide what is important, putting their knowledge together and discussing. We did focus on adults, we didn't discuss about children, and we were facing always in all the discussion the variability of the healthcare system, the universal coverage in some centers and not present, for example, in the USA. Viability of resources, even in high-income countries, there are some low-resource settings in which some tools we are suggesting are not available. And we have a lot of viability, as we know, of end of care and withdrawal decision, and we have also legal and regulatory constraints. We spent 2.5 days, 24 talks. 8 hours of discussion is the minimum we can collect, but we discuss also in the breaks and in the evening. And we will report, Yelena will report 3 content areas that we discuss: diagnosis, intervention, and prognosis. We discuss also about epidemiology, ethics, but we are not going to report here. And the presentation will follow in this order. Yelena will present what is known for each of these topics, which are the gaps, and what can be done now for you at the bedside since today. I leave the floor to Yelena.
Thank you very much. Good morning, everybody. So my task here is to give you the output of our 2.5 days of talks and discussions. And as Giuseppe mentioned, each of the next slides is going to be divided into 3 sections, as you can see on the slide to my left. And we're going to talk about what the literature has shown us so far, where we think that we need to make additional progress, and what you as an intensivist can bring back to your facilities, to your units, when you go back home after this meeting. And really, that was a very big highlight of the past 2.5 days. What can we do right now to improve patient care for patients with disorders of consciousness? So we're going to start with diagnosis and what is known. So the first thing, and this has been demonstrated in the literature many times now, is that we know that the bedside behavioral examination, typically conducted with the Glasgow Coma Scale, is inadequate for detecting the subtle signs of consciousness that Giuseppe alluded to a few slides ago. And we also know with relative confidence that if you use a standardized behavioral assessment, something I'll talk a little bit more about this evening in the plenary, which is a validated tool that it's designed specifically to detect consciousness, you're going to be more precise in your diagnosis and in your prognosis. And this is something that's relatively easy to do and accessible for most clinicians in most settings. We also know that there are some patients who appear unresponsive at the bedside. They don't follow commands, they don't track the room, they don't respond to noxious stimulation. Yet, when they are asked to perform covert tasks, and they are assessed at the same time with functional MRI, with electroencephalography, or with other advanced technologies, they are able to generate a willful response to a cognitive task. And we call that cognitive motor dissociation, something that over the past 20 years has become more and more apparent in the literature. But of course, we have many gaps in diagnosis. Our diagnoses are generally based on behavioral phenotypes, and we lack disorders of consciousness endotypes, the mechanisms that would help us define subtypes of disorders of consciousness that do not rely on behavioral assessment, which of course can be confounded. We also know that the term coma is used to describe a wide variety of patients and behavioral phenotypes of patients. And so we're not catching those subtle stages of recovery of consciousness that we need to be. We know that there's a lack of standardization in disorders of consciousness assessment, that signs of consciousness can be missed, and we know that many of the tools that we have to detect cognitive motor dissociation, although the promise of this phenomenology is very exciting, the tools that we have for assessing it are really not validated and have not been integrated into clinical care. So what can you do today? The first thing is that we want to highlight that identifying treatable causes of disorders of consciousness is a first line of defense. Using electrophysiology, imaging, and other tools, we want to remove anything that could be masking consciousness, confounding the behavioral assessment. We also want to maximize arousal prior to behavioral assessment, whether that's through suctioning or doing deep tissue massage. We want to upregulate the arousal system so that the cognitive response that we are getting is at its peak, is at its maximum. We want to identify and avoid confounders that could mask consciousness, sedation being a very obvious one. We want to limit sedation. We want to use behavioral assessments that are specifically designed to detect levels of consciousness. And we want to repeat those assessments throughout the ICU stay because, as we know, consciousness fluctuates. It goes up and down throughout the day and across the days. And so we want to avoid misdiagnosis and establish a trajectory by repeating these standardized behavioral assessments over time. And finally, as a group of professionals, we want to develop a consensus on disorders of consciousness definitions, especially for acute care, that bring together professional societies across disciplines, not just in neurocritical care, but intensive care as well, to develop consensus definitions. Okay, we'll move on now to interventions. So this is something we discussed about a lot, and we thought a lot about exactly how to put into words the state of the literature as it stands. Right now, we really don't have treatments that have been definitively proven to enhance recovery of acute disorders of consciousness. That's really the emphasis here, is acute disorders of consciousness. We do have some treatments for subacute and chronic DOC, but not acutely. There are also some clinical guidelines for ICU interventions in general, but again, they're really largely based on consensus, and they are not focused on disorders of consciousness. What we do have are some pharmacological and neuromodulatory interventions, actually quite a few, that are under development and that are going through the process of gathering evidence and developing larger trials so that we can bring them into clinical practice. As I mentioned, we lack strong evidence for interventions in disorders of consciousness. And because of that, and because we don't have disorders of consciousness endotypes, we are unable to stratify patients to enroll them in clinical trials, to enrich the sample in clinical trials, and to optimize responsiveness. And that's probably one of the reasons why so many clinical trials in patients with severe brain injury really have failed over the past couple of decades. Our targets for the interventions are precise. Part of this is because we don't understand the mechanisms of disorders of consciousness. And most hospitals and academic medical centers don't have access to experimental interventions at the moment. But what can we do right now? So we want to optimize medical management in the ICU to prevent complications that might be able to enhance consciousness recovery. And another point we had a lot of discussion on is early rehabilitation. There is evidence that shows that for some patients, early rehabilitation is safe and it can be initiated in the ICU. You can even involve families at the bedside to start promoting recovery in a safe way as long as there are no contraindications. So that was really one of those action points that you can start thinking about as you head home. All right, prognosis, what is known? So this is a very important and probably the most studied topic in disorders of consciousness to date. So we know that after a severe brain injury that results in a disorders of consciousness, the range of outcomes spans from death, prolonged disorders of consciousness, return of independence, return to work, and full recovery. We see patients with very serious injuries acutely that make full or near full recoveries months to years later. That is possible. And of course, we see the opposite as well. Patients who are in a prolonged disorder of consciousness and an unresponsive wakefulness syndrome for years to come. That is truly the full range of outcome, despite the fact that some patients can look really devastated acutely. We have some outcome data in hypoxic ischemic brain injury. That's probably the data that's most robust, collected consecutively. Patients are followed long term. In other etiologies, the data are not quite as strong. We also know that withdrawal of life-sustaining treatments happens often, and it happens early. You're going to hear more about that in the next talk. And this affects, of course, not only clinical care, but the results and interpretation of most of our outcome studies. They are mostly all confounded by early deaths that happen after withdrawal of life-sustaining treatment and not necessarily as a direct result of the brain injury. We want to be aware of self-fulfilling prophecies, which essentially means that if we are withdrawing life-sustaining treatment early because we think that somebody's not doing well, because they behaviorally look like they are not conscious, well, that's going to increase the percentage of unfavorable outcomes in our studies, and it's going to affect decisions going forward. So we want to make sure to try to break that cycle of self-fulfilling prophecy. And finally, we want to be aware that prediction models, there are some out in the literature, are not designed for decision-making and treatment about withdrawal. And now for the gaps. Prognosis at the individual acute patient level is imprecise. Withdrawal life-sustaining treatment rates are not reported in many studies, and they should be, and we have no guidelines on when to withdraw life-sustaining treatment. So what do? Prognostication is complicated. We want to be cautious, especially with early withdrawal life-sustaining treatment. We want to use as much information that we can, behavioral imaging and so forth. We want to be very clear to communicate to families that outcome is uncertain, and outcome can include the full range of outcomes. We want to talk to families about what's acceptable to them, and we don't want to put our own belief systems onto them. And we want to avoid dichotomizing outcome into favorable and unfavorable. We want to practice shared decision-making. We want to reevaluate prognosis throughout the ICU course, become familiar with local practices about withdrawal of life-sustaining treatment that might be able to happen in the post-acute setting, and be aware of our own internal biases. And now for a roadmap to the future. No, you go ahead. Okay, I'm going to go ahead. Okay. So, common data elements have been developed for disorders of consciousness, and we should start using them in our daily practice and in research. We need to do epidemiological studies. We need to identify pathophysiological mechanisms of disorders of consciousness and optimize our clinical trial design using precision medicine approaches. And we need to identify predictors of long-term recovery that are meaningful. We really don't have that right now. We need longitudinal DOC registries bringing data in from around the world into a centralized place. Of course, AI is going to be a hot topic, as it has been and it will be in the future. And we really want to promote collaboration between clinicians and investigators across the disorders of consciousness spectrum.
Thank you, Yelena. I think we wanted also to leave you with some take-home points. And I think we wanted to underline that you need to recognize that we are not so good in making prognosis very early. We suggest to maintain humility in making a prognosis and avoid very fast decision-making in this field. We want to suggest also to refine the clinical exam using some behavioral assessment, and we will go in deep detail when we will publish the report of this roundtable. And we underline the importance of shared decision-making. And I think we need to remain updated because this field is changing very rapidly. We want to thank you, the patient and the family that gave us video, their voice, that give us a strong message at the beginning of this roundtable. All the roundtable participants, the audience today, and the EasySem for selecting this topic. And we had some support from the Neurocritical Care Society, and the World Coma Day is coming in the next few days, and Neuroptics for some support, economical support. Thank you very much indeed for your attention.
Thank you very much, Yelena and Giuseppe. And almost as if planned, I'm sure it was, we now have coming up 3 talks trying to help us bridge some of these gaps. And the first one, to be presented by Shaurya Taran from Toronto, Canada, is on decisions to withhold or withdraw life support after acute brain injury.
Thanks so much to the conference organizers for the invitation to participate. My name is Shaurya Taran. I'm a neurointensivist at the University of Toronto, also a PhD candidate at the University of Toronto. And this talk on decisions to withdraw or withhold life support in patients with brain injuries was part of my PhD thesis work. Also happy to share that it is published as of this morning, actually, in the Lancet Respiratory Medicine and should be accessible from the table of contents of the journal. So to set the context for this talk, it dovetails nicely with a lot of what we've heard already by Professors Citerio and Bodien. We know that withdrawal of life-sustaining therapies, or WLST as I'll refer to it throughout this presentation, is a common cause of death in patients with acute brain injury conditions admitted to the ICU. We also know that WLST decisions in this population occur early and are often driven by clinicians' perception of a poor long-term neurologic prognosis. Variability in withdrawal decisions across ICUs is very high, and some patients who are perceived to have an unfavorable prognosis by their clinicians and by their healthcare providers may go on to demonstrate long-term neurologic recovery. Many of you will be familiar with this landmark paper by Jan Klaassen and colleagues published several years ago in the New England Journal, where 15% of patients who were behaviorally comatose actually demonstrated evidence of command-following behavior when interrogated with EEG. And of those patients, 44% were able to function independently for at least 8 hours 1 year following their injury. So that context motivated the following study questions. Do clinicians approach withdrawal of life support decisions differently in patients with brain injuries compared to those without brain injuries? Are there differences in the timing of WLST decisions? And is variability in WLST decisions across ICUs different for patients with brain injuries compared to those who have any other reason for being in the ICU? In other words, we expect variability to exist. It's part and parcel of how we make decisions in our local and regional practice settings, but is the magnitude of that variability different depending on the diagnosis you come in with into the ICU? So to answer those study questions, we did a secondary analysis of 2 prospective cohort studies. The first was the International Study of Mechanical Ventilation, conducted at 3 different time points in 2004, 2010, and 2016. It was a series of 3 linked cohort studies published by Professor Penuelas and colleagues in ICM in 2020. And the second study was the International Observational Study published by my colleague in Toronto, Karen Burns, in JAMA. This was a study that prospectively recruited patients between 2013 through 2016. We defined in our secondary analysis the main exposure as an acute brain injury condition, which was essentially any of acute ischemic stroke, intracranial hemorrhage, which also includes spontaneous subarachnoid hemorrhage, traumatic brain injury, seizures, status epilepticus, and also meningitis and encephalitis conditions. The comparator was any non-acute brain injury condition requiring ICU admission, so any diagnosis that wasn't of one of the 5 previously listed, and the main outcome was a composite of withdrawal or withholding of life-sustaining therapies. Withdrawal events were defined as the discontinuation of non-invasive or invasive mechanical ventilation, vasopressors, inotropes, or dialysis, and withholding events were defined as the non-escalation to or the non-offer of any of those preceding therapies, in addition to the non-offer of cardiopulmonary resuscitation. The analysis was done after merging common covariates between the 2 data sets to create a single harmonized cohort. We then looked at time to WLST using cumulative incidence curves that account for the competing risk of death in the absence of a withdrawal decision. We created adjusted models using mixed effect logistic regression that adjusted for various patient-level characteristics, ICU characteristics, and also included a random intercept for ICU site to account for clustering at that level. And then in the variability analysis, we calculated median odds ratios for each subgroup of patients with and without acute brain injury using random slopes from the model. This method has been described by one of my colleagues in Toronto, an intensivist and researcher, Chris Yarnell, and we adapted that approach for the present analysis. So here, this is an abridged version of our study flowchart. We included just under 22,000 patients between 2004 through 2016 from 40 countries worldwide. Most of these patients were coming from the ISMV cohort. We included just under 17,000 patients in the analysis of withdrawal of life-sustaining therapies. One of the ISMV cohorts didn't have that information, and that essentially was removed from that particular analysis, hence that discrepancy between the 2 numbers. So here we're looking at the baseline characteristics of patients stratified by their ICU diagnosis. I'll draw your attention first to the fact that just over 13% of this cohort was composed of ABI patients. The remaining 87% had non-ABI patients as the reason for their ICU admission. We're now stratifying their baseline characteristics according to the standardized mean difference, where values greater than 0.1 are statistically significant. Draw your attention first to the fact that the age of brain injury patients was lower than those without brain injury conditions, and on average, most patients with brain injury conditions had fewer comorbidities at ICU admission compared to those without brain injury conditions. So that leads to our first take-home point here. Brain injury patients were younger and had fewer overall comorbidities compared to their non-ABI counterparts. The reasons for ABI conditions were primarily traumatic brain injury and intracranial hemorrhage, which also, again, includes subarachnoid hemorrhage. Looking at their characteristics on day 1 of ICU admission and focusing specifically on the sequential organ failure assessment scores, you can see that the values are higher in the non-ABI cohort across all these organ domains as compared to patients with brain injuries. So that leads to the next take-home point. Brain injury patients had lower organ injury scores compared to non-ABI patients. So we've established that they're younger, they have fewer comorbidities going into the ICU, and lower organ injury SOFA scores at ICU admission. That being said, their withdrawal rates are higher. At any point, WLST occurred in 17% of patients with a brain injury condition compared to 11.5% of patients without brain injuries. That's an unadjusted risk difference of 5.5%, standardized mean difference of 0.16, both being significant. Not reported in the table, but reported in the main text, most of these decisions, in fact 82% in our cohort, were followed by in-hospital death of the patient. So here we're going to be looking at a series of cumulative incidence curves stratified by the underlying diagnosis, with censoring at day 60 and time point 0 being day 1 of ICU admission. So this is WLST up to 60 days in the overall cohort. You can see that the decisions are occurring earlier in patients with brain injury and the cumulative incidence is higher. This is highly statistically significant by Gray's test. Looking at the early decisions that happen in the first 7 days, often a time point where neuroprognostication is fraught with uncertainty, again, you can see that these decisions are being made earlier in brain injury patients and the incidence is higher. What about across countries? Is there any effect modification based on where patients are managed? So we looked at high-income countries and upper-middle-income countries separately, and we saw, in fact, there was no difference based on country of management. These decisions were almost universally, one could say, occurring earlier in patients with brain injury conditions. Median time in the overall cohort to a WLST decision was 4 days in patients with brain injuries and 6 days in patients with any other reason for being in the ICU. Was there effect modification by cohort year? In other words, are we making decisions differently with time. So we looked at 2 different cohort years, 2010 and 2016. You can see, again, that there doesn't appear to be effect modification by time. What about across subgroups? Are the subgroup-specific effects different from the overall cohort effect? So here we're going to be looking at traumatic brain injury, intracranial hemorrhage, and ischemic stroke separately, and the denominator is going to be a non-ABI condition across all comparisons. Traumatic brain injury, decisions are made earlier. Intracranial hemorrhage, decisions made earlier. Ischemic stroke, same story repeats itself. To set the context for comparisons, we also looked at other very common reasons for ICU admission, sepsis and ARDS. We're very familiar with those as intensivists, manage them frequently. There's no difference in time to a WLST decision in patients with sepsis versus non-sepsis conditions, and the same is true for patients with ARDS. So here we're looking at the association between ABI and WLST from the full model that's adjusted for patient covariates and ICU factors. And you can see that having a brain injury condition predisposes to nearly a 2.5-fold increase in odds of WLST compared to having any other reason for being in the ICU. And that finding is replicated across multiple sensitivity analyses where we look at the data a little bit differently. These are factors associated with WLST from the main analysis model. For brevity, I've removed various analyses from the supplement that look at multiple additional confounders, essentially drawing your attention here to the fact that ABI diagnosis is the factor that has the strongest strength of association with WLST. It's stronger even than older age compared to age less than 50 years old, and stronger than all of the individual organ SOFA scores at ICU admission. So to reiterate that point, the magnitude of the association between ABI and withdrawal of life support is higher than for any other covariate in the model, including risk factors that we know to be associated with WLST decisions, such as older age and individual organ injury scores. Here we're looking at the subgroups and their association with WLST decisions. You can see that for traumatic brain injury, hemorrhagic stroke, and ischemic stroke, the association with WLST is higher than for the comparator. Whereas, on the other hand, sepsis has a lower association with WLST compared to non-sepsis diagnosis, and for ARDS, that association is not significant. These are fully adjusted models, covariates used for adjustment being the same across all models to promote comparability. Here we're looking at variation in WLST using the median odds ratio. Again, the median odds ratio can be conceptualized as the change in odds when a subject is moved from a randomly selected lower odds cluster to a higher odds cluster. And the higher the median odds ratio, the higher the extent of variability. The point estimate from all of these models is high. It's on the order of 2.5 to 3 in most of the analyses, suggesting that variability is an important component of our WLST practices regardless of underlying condition. Now, it doesn't seem to be related to the fact that you have a brain injury condition or not, at least based on this frequentist interpretation using p-values, with all of them being greater than 0.05 in the main analysis and across all of the sensitivity analyses. So the take-home point here is that the median odds ratios are high in all analyses, suggesting significant variation in WLST decisions, irrespective of the underlying diagnosis, and this is true across all ICUs. In secondary analyses, we looked at the association between brain injury and mortality. In the main analysis and in the sensitivity analyses, the association between brain injury and mortality was higher than having a non-brain injury diagnosis. All of the sensitivity analyses were adjusted for the same patient-level covariates, again, to promote comparability with the main models. So where does that leave us? Well, I think we can say that WLST, at least based on this cohort, is more common in patients with brain injury conditions, and it occurs earlier in this group compared to patients without brain injuries. Now, this isn't just decision-making in the absence of real implications. Most of these decisions were leading to death of the patient in 82% of cases, in fact, in our cohort. Variability in these decisions was high across ICUs. Now, the median odds ratio was higher in terms of its point estimate than any of the other fixed effects in the model, suggesting that, again, our local practice patterns exert as much influence, if not potentially even more, than patient-level risk factors for WLST decisions. And I think that was an important take-home point, at least for me, when we were interpreting these results. And I think when you put this all together, it makes me wonder, should make one wonder, whether thresholds to consider WLST might be different in patients with brain injury conditions compared to those without ABI admitted to the ICU. This is challenging because early WLST decisions might occur because of a perceived poor neurologic prognosis. Whereas we know from work that we've just seen in the previous presentation, early neuroprognostication can be inaccurate. This has been shown time and time again in work done from the NCS, in their guidelines, in the cardiac arrest literature. We also know from work, again, done by Dr. Bodien, that some patients with early WLST could have had an acceptable neurologic outcome in the absence of a WLST decision. That being said, this research needs to be interpreted within its the following caveats. Unmeasured confounding is likely because we didn't have access to all of the data that clinicians would typically consider before making these decisions. We can't say anything about the appropriateness of these decisions because that's simply not discernible from this data. We didn't have access to communication patterns of, the dialogue between practitioners and SDMs, or substitute decision makers, before these WLST decisions were made. We also included WLST events as a combination of withholding and withdrawal events. This is how the data were reported in the primary studies. It's unclear whether the signals that we observed were driven, for example, by withholding events versus withdrawal events, and this requires future studies to clarify. It's also possible that findings may be different in newer cohorts. We use data up until 2016. It's unknown what's happened in the last 9 years and whether increasing familiarity perhaps or recognition of the limitations of early WLST decisions might have affected findings in newer cohorts. This work was made possible by a very large team of people from Toronto and beyond, some of whom are in the audience today. It was also supervised by Dr. Neil Adhikari, who unfortunately couldn't be here today. He's an intensivist out at Sunnybrook and also my PhD supervisor. Thank you so much for your attention.
Thank you, Dr. Taran, for sharing the results of this study. I think all of us who care for patients with acute brain injury will agree that this is a common challenge, and I'm sure this analysis will trigger a lot of debate. So time to move on to the next presentation. I would like to invite Matthieu Jabaudon to the podium. He is based in Clermont-Ferrand in France, and he will be presenting on inhaled sedation in acute respiratory distress syndrome, the SESAR trial, with an S.
Good morning, dear colleagues. I'm very happy to be here, and I wish to thank the EasyChem organizers for this opportunity to present you the results from the SESAR trial, which was a trial of inhaled sedation in acute respiratory distress syndrome. So these are the disclosures for the trial. It was funded by the French Ministry of Health and grants from the European Society of Anesthesiology and Intensive Care, and received financial and logistical support from Sedana Medical. The sponsor was the University Hospital of Clermont-Ferrand, and these are my personal conflicts of interest. So current guidelines for ICU sedation suggest the use of light sedation targets as opposed to deeper sedation targets in ICU patients under mechanical ventilation. However, these guidelines recommendations can prove difficult to apply to patients with severe forms of lung injury, such as acute respiratory distress syndrome, and these patients often require deeper sedation targets to facilitate lung protective ventilation and decrease the risk of patient ventilator asynchrony. Among intravenous sedative drugs available, we should avoid benzodiazepines because they increase the risk of delirium and increase duration of mechanical ventilation. And dexmedetomidine can be useful in many settings, but it's not always applicable to patients under deep sedation. Leaving propofol as the main agent being used, at least in most European countries, for ICU sedation. Since almost 20 years now, some dedicated devices allow the use and the delivery of inhaled anesthetics or volatile anesthetics such as isoflurane or sevoflurane for ICU sedation. These drugs have pharmacological features that may be appealing, such as a low metabolism rate by the liver and also a short onset and offset of action. A large randomized trial in Germany and Slovenia, including 300 patients, showed non-inferiority of isoflurane versus propofol for the proportion of time spent in the sedation target. This trial has led to the official labeling of isoflurane for ICU sedation in adults in some European countries. More recently, a systematic review of 9 randomized controlled trials found decreased awakening and extubation times, decreased length of stay in the ICU, and decreased mechanical ventilation duration in patients receiving inhaled sevoflurane or isoflurane. In parallel to data from preclinical models, one first pilot randomized controlled trial from our team suggested a few years ago that inhaled sevoflurane was associated with improved oxygenation and decreased levels of markers of inflammation and of lung epistellal injury in patients with moderate or severe ARDS compared to intravenous midazolam. With this in mind, we designed the SESAR trial to evaluate whether in patients with moderate to severe ARDS, a strategy of inhaled sedation with sevoflurane as compared with a strategy of intravenous sedation with propofol would increase the number of days alive and free from invasive mechanical ventilation through day 28. Recruitment occurred between May 2020 and October 2023 among 37 French ICUs. Ultimately, 32 of these ICUs actively recruited patients. The inclusion criteria were adult ICU patients with Berlin criteria for ARDS for less than 24 hours, and severe hypoxemia as reflected by a PaO2-FiO2 ratio below 150 millimeters of mercury and a PEEP of 8 centimeters of water or more. The main exclusion criteria are listed here: pregnancy, a history or a predisposition for malignant hyperthermia because the risk is increased with volatile anesthetics, hypersensitivity to study drugs, and being mechanically ventilated for more than 5 days or needing ECMO before enrollment. Patients were randomized to either intravenous propofol or inhaled sevoflurane on a 1:1 ratio, and randomization was stratified on site, on the need for vasopressor support, on PF ratio below or above 100 millimeters of mercury, and on suspected or proven COVID-19 at enrollment. In the intervention group, patients received sevoflurane through the Sedaconda ACDS device from Sedana Medical, which is basically an HME filter which also vaporizes and reflects the agent and that you would place between the tracheal tube and the Y-piece of the respiratory circuit. The initial strategy in both groups was that of deep sedation associated with neuromuscular blockade, which was stopped, and light sedation was targeted as soon as oxygenation improved, such as in the PROSEVA trial. The protocol for sedation included an analgesia-first-based approach and interruption of sedation as soon as possible, along with weaning from mechanical ventilation. In the intervention group, sevoflurane could be delivered up to 7 days if sedation was needed. After that, clinicians could decide on their strategy and the sedative drug to use. Out of 2,016 patients, a total of 700 were randomized, and after exclusion of patients who withdrew consent or who were placed under judicial protection, the modified intention to treat analysis included 346 patients in the sevoflurane group, 341 patients in the propofol group. Characteristics at baseline were quite balanced between groups. Mean age of 65 years old, 30% of patients were female patients. Their medical history included hypertension and type 2 diabetes at the most. Patients were randomized at a median time of 1 day after their ICU admission and on the same day, for most of them, same day of intubation. ARDS was caused by pneumonia in 84% of cases, and COVID-19 pneumonia represented 55% of the enrolled population. 3/4 of the patients had vasopressor support, mostly norepinephrine, at enrollment, and 2/3 of them were free from acute kidney injury before randomization. Most patients received volume-controlled ventilation. Their tidal volume at baseline was 6 milliliters per kilogram of predicted body weight under a PEEP of 10 centimeters of water, respiratory rate of 26, PF ratio around 110 millimeters of mercury, under a FiO2 of 75 to 80%, without any significant differences between groups. Most patients had already received continuous neuromuscular blockade with cisatracurium before randomization, 88%, without any differences between the group. And more than a third of patients also had received prone position before randomization. So these are the sedation depths in both groups, the maximal Richmond agitation sedation score in the upper part and the minimal RAS score in the lower part. So patients basically received deep sedation targets with similar patterns between groups, and for a total duration of 7 days as a median value without differences between groups. During the 7-day intervention period, the median sedation duration with the studied drug was 5 days for sevoflurane, and it was 6 days for propofol. As you can see on these figures, polypharmacy was frequent, meaning co-sedation with other agents out of the trial drug. And in particular, in the sevoflurane group, patients, a non-negligible proportion of patients also received propofol as co-sedation. So this is the primary endpoint of the trial, the number of ventilator-free days through day 28, median values of 0 in both groups, but a median difference reaching significance of minus 2.1 days, which did not favor sevoflurane, but favored propofol. Using a mixture model, the standardized hazard ratio for this effect was 0.76, and all these results were similar after multivariable adjustment in 2 per protocol populations and in the sensitivity analysis, excluding the first 5 patients enrolled at each site to assess whether any learning curve effect would have occurred during the trial. Our key secondary endpoint was 90-day survival. As you can see, there were more deaths in the sevoflurane group, 53% at 90 days compared to 44% in the propofol group, which reached statistical significance. Among secondary endpoints, there was a higher 7-day mortality in the sevoflurane group, along with fewer ICU-free days through day 28 for the intervention. So, of course, our trial has many limitations. We could not technically blind the intervention for logistical reasons, but the sedation scores were similar between groups. Polypharmacy was frequent, and with contamination with propofol in the sevoflurane group, whether this has influenced the results remain unknown. Our trial shows deep sedation and long sedation practices along with long paralysis duration. It was a median duration for neuromuscular blockade of 5 days in both groups without any difference. This may simply reflect the difficulty of managing these patients with severe ARDS. The patterns, at least, were the same in both groups. And the outcomes in the propofol group align with those of recent RCTs in ARDS, such as the ROSE trial, further reinforcing external validity. We did not collect data on concomitant opioid analgesia, nor on sevoflurane's expired fractions, which are good surrogates for sedation depth. At least these fractions were available to clinicians to guide to titrate sedation during the trial. The strength of the trial now, it's a multicenter trial with pragmatic design. Our findings were consistent across all outcomes, And this is to date the largest randomized trial on inhaled ICU sedation. And we are now waiting for other trials in patients with ARDS and also in patients without ARDS to further inform safety of inhaled sedation in the ICU. So my take-home message is this is the first large phase 3 multicenter trial of inhaled sedation in ARDS, showing in patients with severe hypoxemia that inhaled sevoflurane compared to intravenous propofol resulted in fewer days alive and free from invasive ventilation through day 28 and lower 90-day survival. We need more research now to understand why we saw these effects. We could find deleterious effects on hemodynamics with higher norepinephrine requirements, with higher serum lactate levels in the intervention group, along with more acute kidney injury under sevoflurane. The intervention group also exhibited higher PaCO2 levels and lower arterial pH, which may raise issues on the dead space volume associated with the device. And patients received higher respiratory rate when they were under sevoflurane, which may have increased mechanical power, although our trial can't conclude on these aspects. COVID-19 pneumonia was the predominant ARDS cause in our trial. However, our predefined subgroup analysis showed worse outcome with sevoflurane in patients without COVID-19 as compared to those with COVID-19, at least for 90-day survival and 28-day mortality. So on this, I wish to thank all participants, their families and next of kins, trial staff at all sites, and I wish to have a special thought to Christophe Vincenot, who passed away last year, who was an investigator in Béthune and who did not see these results. I would like to mention and thank again our funding sources, our sources for support, all the team at EasyChem for inviting me to present these results, and all the teams at JAMA, because hopefully the paper is now available or should be soon available through this QR code. Thank you very much.
Thank you very much, Matthieu. Certainly, I was saying this is not something I've had access to, so it's very interesting to hear about. Our next talk will be by Romain Pirracchio from San Francisco in the United States, and he'll be speaking on optimal vasopressin initiation in septic shock.
Good morning, everyone. I am Romain Pirracchio from UCSF, California. First of all, I'd like to extend my deepest gratitude to the chairperson and to the EasyChem organizer for inviting me to present the results of our study called OVIS for optimal vasopressin initiation in septic shock. This is my disclosure slide, and let's dive right in. So this is the topic today. We're talking about sepsis. And as I'm sure you're all aware of, we're dealing with a medical crisis here. As of 2020, this is the report from 2020 WHO, the incidence of sepsis worldwide reaches almost 200 per 100,000 person years. And the overall mortality is greater than 25% overall. If we only consider the patient we are treating in the ICU, it's close to 42% worldwide. So again, this is a real medical crisis. What can we do about that? Well, we can certainly follow our guidelines, and we do have very strong international guidelines on sepsis. And I'm using here the Surviving Sepsis Campaign guidelines. That guidelines actually encompasses 79 recommendations in total, 22 of them that should be applied within the first 24 hours. And a couple of years ago, together with my team, we started working on that, on the guidelines, together with data and with machine learning / AI type of tools to actually identify a subset of those guidelines that should be prioritized by the clinician at the bedside. And we actually identified, based off of that, a bundle of 6 recommendations that were associated with a decrease in 28 days mortality compared to providing less and with no difference compared to providing more. So essentially, this bundle of 6 seemed to be sort of the golden bundle to decrease mortality when applied during the first 24 hours. And interestingly enough, among those guidelines, we add vasopressin. So let's take a deeper dive in that and look at the last iteration of the Surviving Sepsis campaign. And you can see here that vasopressin is indeed recommended as a second-line vasopressor for patients with septic shock. But you can also see here that the recommendation strength is considered to be weak, and the level of evidence is considered to be moderate at max. So let's take a deeper dive into the studies. And certainly, the study by Russell, published in 2008 in New England Journal of Medicine, is a landmark trial for vasopressin. As a brief reminder, in this study, the authors randomized patients that were already on low-dose vasopressin to either escalate the norepinephrine dose to reach their MAP goal, or to include, to start vasopressin to actually reach the same MAP goal. And as you can see here on the Kaplan-Meier curve on the right side of the slide, there was no difference in mortality between the two strategies. But what was interesting to us is a subgroup analysis that actually showed on the lower part of the slide, in patients with less severe septic shock, a benefit of the vasopressin strategy, with no benefit in the more severe group of septic shock. So maybe here a hint that treating patients early with vasopressin may actually be better. So do we have other data to support that? Well, there's actually a bunch of observational studies that looked at that, and I'm just citing this one that was released last year, that looked based off of retrospective data at 2 different groups defined by vasopressin initiation, either early, within 6 hours following norepinephrine start, or later, after 6 hours. And as you can see here in the table, while being part of the early vasopressin group was actually associated with a decrease in mortality. And what was interesting here is that on the left side of the slide, if you look at the severity of the 2 groups, well, you can see that in blue, the early vasopressin group were actually patients that were more severe, at least based off of their pH or their lactate level, which sort of makes sense. The more severe, the more aggressive you are, the earlier you start vasopressin, but almost counterintuitively, those patients tend to survive more. What are the practices? Well, we actually did this survey a couple of years ago looking at broad practices when it comes to hemodynamic resuscitation for patients with septic shock. And what we actually showed here, highlighted in red, is a broad range of practices in terms of the second-line vasopressor, ranging from no use of vasopressin all the way to introduction at different thresholds based off of the norepinephrine dose. So the question at stake here was when to start vasopressin. So we started and designed the OVIS trial to derive and validate a reinforcement learning algorithm for determining the optimal initiation rule among patients hospitalized in the ICU for septic shock already under norepinephrine. The primary outcome was in-hospital mortality. So let's pause here for a minute and talk about reinforcement learning. So in a nutshell, you can see reinforcement learning as 2 things. First, an environment, and second, an agent that will take action within this environment. And the agent will receive 2 feedbacks. The first one is a change in state. In our case, the patient will change state based off on an action. And the second feedback is actually a reward or a penalty based off of the impact of the action on the environment and the patient. So the environment in our case was a set of 121-hour time blocks that covered 5 days worth of ICU stay. The action was to start or not start during each one of the time blocks the vasopressin infusion. The state was defined in each time block based on 14 different clinical parameters, ranging from treatment all the way to clinical and biological parameters. And finally, the reward was based, of course, on longer-term outcome, survival or mortality, which was given the highest penalty in the model, and also shorter-term outcomes like MAP, norepinephrine dose, SOFA score, or change in the lactate level. So how did we use reinforcement learning? Well, we used a set of 3,608 patients in septic shock, according to Sepsis 3, with no exclusion criteria, from 5 California hospitals. And then separately from that, we used a data set of more than 10,000 patients from 232 hospitals across the US to actually evaluate the model based on 2 things. First of all, the performance of the model itself, and second, the clinical impact of vasopressin. So to evaluate the performance of the model, we use what we call weighted importance sampling. This is what we called an off-policy method, which means that we're able to evaluate the performance of the model without having to deploy it in practice. So we're using retrospective data for that. And to evaluate the performance, we look at the reward, as previously defined, and we sum up the reward over all the time blocks to actually come up with a reward associated with the reinforcement learning decision itself, and a reward associated with the observed clinical actions in the data. And then, because this reinforcement learning model, again, was not deployed in practice, we had to take that into account and to weight the probability of acting per the reinforcement learning rule versus acting per the observed clinical decision, and this is where the weighting comes into play. Then the clinical impact, of course, is of huge importance, and again, our primary outcome was in hospital mortality, and we had to take into account the fact that this clinical decision-making process of deciding during each one of the time blocks to start or not start vasopressin is, of course, confounded or is driven by a lot of time-varying cofactors. So to take that into account and to evaluate the impact of complying with the reinforcement learning rule recommendation during each one of the block, to evaluate this impact on mortality, we had to take this structure into account, and we use a pool logistic regression to estimate the hazard of death in each time epoch, weighted by inverse probability of treatment weighting, again, to take into account the dynamic nature of the intervention. The population, so again, close to 15,000 patients. The derivation cohort, age 63, 57% male, SOFA score of 5. And the validation cohort was very similar, age 67, 56% of male, and SOFA score of 6 at baseline. So let's jump into the first set of results. I want to draw your attention here on the first row in red. This is the proportion of patients that received vasopressin based on the data. So you can see here that 31% of the patients did receive vasopressin, while in contrast, in 80% of the cases, the rule, the reinforcement learning model, suggested initiation of vasopressin. So much more patients were suggested to requiring vasopressin by the model. And then if you look at the 4 other rows, you will see that the reinforcement learning model consistently suggested starting vasopressin earlier relative to the onset of shock, relative to the dose of norepinephrine, relative to the SOFA score, or relative to the lactate level. Regardless of the parameter, the reinforcement learning model suggested starting earlier. This is the result for the model performance. So again, the total reward. And here I'm presenting the difference in reward. If the difference is positive, this favors the model. So you can see here that the overall reward was actually greater. So the difference was positive, suggesting that the reinforcement learning model reached a better reward, a greater reward than the clinician. And you can see that this was the case for the overall reward as well as for each one of the components of the reward, be it mortality, MAP, SOFA score, lactate, or norepinephrine dose. Here's the results on in-hospital mortality. On the left side of the slide, the odds ratio. So if the odds ratio is actually lower than 1, it reflects a benefit of the reward of the reinforcement learning model. And as you can see here, the first part on the left side of the slide suggests that the overall mortality when complying with the reinforcement learning rule was actually lower than when there was no compliance with the recommendation with the rule, which reflects is reflected in the survival curves on the right side of the slide. The other thing I wanted to point you at is this part of the slide where we actually tested much simpler rules based off of very simple clinical parameters that we may sometimes be using at the bedside to start or not start vasopressin. The lactate level, the dose of norepinephrine, or just the time since the onset of septic shock without reaching the MAP goal of 65. None of this very basic clinical rule actually outperformed the clinician action, nor did they outperform the reinforcement learning rule. So what are the strengths of our study? Well, first of all, reinforcement learning can be used to optimize the decision-making process over time through interaction with the environment in a complex setting. The model was derived and tested in 4 independent cohorts, large, real-world EHR data with diverse patient and case mix. The model was trained using very basic clinical parameters and biological parameters that are all available in EHR, rendering this model easy to implement in practice. And in fact, this model is being implemented in practice right now. And all the performance were actually consistently confirmed using multiple different analysis, sensitivity analysis, and across different subgroups based off of age, sex, race, and ethnicity. We do have some substantial limitations, though. The first one is that it is not a prospective study. This is a retrospective study. And of course, we will need to prospectively test the algorithm in a randomized trial. And this is planned for, hopefully, the next couple of years. The model was derived offline. So, of course, there is the possibility, and it is likely that unmeasured confounders are present. And so, again, this will require a prospective study to be tested. The rule focused only on initiation of vasopressin and not on dosing or weaning. Longer-term outcomes were not available in the study. And finally, we used data from hospital. We did not use data from hospitals from low and middle-income country, which questions the validity of our model outside of the setting that was used to actually derive the model. So as a conclusion, a reinforcement learning model developed and validated in several observational data sets recommended more frequent and earlier use of vasopressin than average clinical patterns, and it was associated with reduced mortality. I want to use the last couple of seconds to thank the team from UCSF, from UPMC Pittsburgh, from Johns Hopkins Baltimore. Amazing team. None of that would have been possible without them. And of course, thanks the patient who provided their data. And I'm extremely excited to say that this paper is being simultaneously released in JAMA. So if you want to look at the full paper, you can scan this QR code. Thank you so much.
Thank you very much, Professor Pirracchio. Very important insights and a nice example how machine learning and advanced analysis can provide us with more information. I would now like to invite Jan Bakker to deliver the Max Harry Weil lecture. Professor Bakker currently divides his time between Santiago de Chile and Rotterdam, the Netherlands. His topic will be blood lactate levels, past, present, and above all, of course, the future. Please, Jan.
Thank you very much, Jan, for the introduction. And thanks to Jean-Louis and Fabio to give me the opportunity to honor a remarkable person, Harry Weil, and one of his passions, lactate levels. These are my conflicts of interest. When Max Harry Weil died years ago, we wrote a tribute on what was his basically legacy. And his legacy, of course, was circulatory failure. And he came up with this triangle of, let's say, characteristics of shock. And of course, you have to have, at least that was his opinion, you have to have an increased lactate to be in shock. But more importantly, he also had added context, like clinical signs, altered mentation, mottled and clammy skin, and oliguria. And all of these factors together were the characteristics of what Harry Weil called shock. Now, what's important, and Max Harry Weil already said, he created already context. So I was invited to present a case in the winter workshop with two esteemed professors in the panel, Jean-Louis and our tribute to our Italian colleague. I presented the case. I didn't give much specifics, but I presented the numbers. And then finally gave the lactate level. And remember, a lactate of 4.5 is associated with 50% mortality. I asked Jean-Louis and Luciano what to do. And they were very excited because this is a real problem. This is a patient in real trouble. And so they suggested to do a lot of stuff and treatment up until I presented the patient, because the patient was in his room drinking coffee and watching television. And so when I created the context, then both Luciano and Jean-Louis said, yeah, but now it's completely different. I mean, it's still an abnormal level, but we won't give fluids. I mean, he's already getting fluids. We're not going to get fluids and vasopressors and whatever to this patient because the context is completely different. And I think that's a major element of not only blood pressure and stuff like that, but also lactate. And lactate is a simple molecule. Lactate is a part of our metabolism. We use lactate to use as an energy source. We, in critical care, use L-lactate. There is D-lactate from bacteria, which gains a little bit of interest. But in our clinically setting, we use L-lactate. The pKa is very low. So lactic acid in and of itself does not exist in our patients because the majority of hydrogen ions is metabolized. As I said, it's a source of energy, so muscle, brain, even the cardiac muscle can use lactate as a source of energy. And already from the first description in 1843, the clinical context of increased lactate levels was clear. Joseph Scherer, a German biochemist, already showed this in the first person where he measured, after the person was deceased, the clinical context. A young woman, Eva Rumpel, who gave birth at 23-year-old and basically got into what we would call now septic shock. Sweaty, rapid pulse, delirious, anxious breathing, cold extremities, and ultimately losing consciousness. That in the session, in the context of infection, is now clearly septic shock. And so that's already in the first demonstration of lactate. Now, this is the metabolism of glucose and ultimately the production of lactate. And some enzymes play a key role, apart from the hypoxemia in the Krebs cycle. But already before you get into Krebs cycle and requiring oxygen, phosphofructokinase and pyruvate dehydrogenase play a role in increasing lactate levels without any, let's say, problem in oxygenation. And already demonstrated a long time ago, in the 1950s, Huckabee already showed that if you get an overstimulation, an overconcentration of pyruvate, so too much pyruvate to be metabolized in the Krebs cycle, you start to get increases in lactate levels. So you infuse pyruvate, you get an immediate increase in lactate levels, you stop the infusion of pyruvate, lactate disappears. Has nothing to do with shock, has nothing to do with tissue hypoxia. And the same for something that we frequently see in our patients, and that's hyperventilation. If you hyperventilate and have alkalosis, you will start to increase your lactate. If you stop hyperventilating, lactate goes down. You hyperventilate again, lactate goes up and goes down when you stop. And so these very simple interventions in lactate metabolism, which have nothing to do with tissue hypoxia and the stuff that's killing our critically ill patients, can have a lactate signal. And already at that time, they said, well, if you want to use lactate to draw immediate conclusions on this is tissue hypoxia, you have to be careful. And that still holds. Now, we know lactate from studies like this, where we decrease the delivery of oxygen either by, in this case, this was an experiment by Haibo Zhang when we were both in Brussels, inducing tamponade, decreasing cardiac output, so decreasing oxygen delivery, and nothing much happens until you reach this critical threshold. Up until that point, the oxygen consumption remains the same. There is hardly any lactate production. But when you pass this critical threshold, you get a rapid decrease in oxygen consumption, and lactate starts to increase significantly. And this was tamponade by reducing cardiac output, but it's the same if you do the same experiment by reducing DO2, oxygen delivery, by decreasing the hemoglobin or either the oxygen saturation, so basically the arterial content. And in my time I spent in Brussels to do ultimately my PhD, I looked at the literature and said, well, if there is this DO2, VO2 dependency, so you change DO2 and then VO2 changes, this is basically present when you have increased lactate levels. So if you have an increased lactate level in the context of shock, and you have, and you look at the relationship between DO2 and VO2, there is dependency. And so these patients are indeed probably hypoxemic. Gilberto Friedman did a more conscious, let's say, prospective approach to this, because he actually studied patients, and he defined phase A and phase B. And so phase A is oxygen supply dependency. You increase DO2, VO2 increases. This was associated with lactate levels, 3.3. Phase B, where the patient was independent, the consumption was independent of the delivery, and so basically a physiological state characterized by completely normal lactate levels. So there seems to be in clinical practice this association with increased lactate levels and basically tissue hypoxia. Now, the next thing is, what if you treat? Can you treat this, let's say, abnormality, and will this have effect on the lactate level? This is what Haibo Zhang did in the tamponade model. So he induced shock, increasing the amount of fluid in the pericardium, decreasing cardiac output, ultimately coming to a state of supply dependency where he ended up with a lactate of around 4. And then he started removing the fluids from the pericardial space, increasing cardiac output. And basically, it's not completely correct, but basically what happened is lactate returned to normal levels. And so the prospect of treating this, let's say, inadequacy between DO2 and VO2 results in normalization of lactate levels in tamponade, but not in sepsis. This is a study Michel van Genderen did, one of my PhD students in Rotterdam, and we compared this tamponade model with a sepsis model. And so the sepsis was an endotoxemic model in pigs, and the tamponade was infusing fluid in the pericardial space, and we decreased cardiac output to 50% of baseline. And what happened is, as you can see, lactate, this is the obstructive shaft, lactate normal at baseline, then increases to 5.1. You immediately return cardiac output to baseline by removing the fluids. It takes some time. The time constant of lactate is not like seconds, but it's a little bit longer. But at the end of the day, lactate returned to completely normal. When you look at the sepsis model, we decreased cardiac output by 50% by just waiting. That's what happened. Every sepsis is a hypoperfusion model. And so you get hypoperfusion by waiting, then you resuscitate, and you can resuscitate the microcirculation with fluids, but you cannot get the lactate level back to normal. And so there is a different, let's say, importance and relevance of lactate levels in different models. And that's what we described in the paper, the 10 pitfalls of lactate clearance in sepsis, and Eva Vink that described the practical use of lactate, where we discuss all these factors that may affect either the clearance or the absolute number of lactate, and that you have to be cautious of when you use lactate in clinical practice. Nevertheless, whatever all the problems associated with lactate, there is a very strong relationship between lactate and outcome. And this is old. This is 1965, many, many years ago. And you can see the lactate level on the x-axis and the mortality. And as you can see in this study, there was no survival if you had a lactate level of more than 13. 45 years later, we did a lactate study in the Netherlands. And in the control group, where we did not treat patients according to their lactate levels, this is the relationship between lactate and survival. In that context of advanced critical care in a developed country, with access to everything that you have in an intensive care, there was no survival if your lactate was more than 10. That's 45 years later. And so the combination between increased lactate and ultimate survival outcomes, whatever you want to use, is still strong after this very long period. Now, does it predict outcome everywhere? Is it of value in every context? Pre-hospital, we have quite a few studies. If you look very closely or take a picture and enlarge, you can see this very handsome guy over here, me in my younger years. We did a study in pre-hospital care and looked at the value of lactate in this context. And it showed that, yeah, indeed, if you have lactate, if you as an ambulance personnel come to a patient, and we did this lactate measurement like a glucose, a finger stick, if the patient had increased lactate, the patient was in trouble, absolutely. So significant evidence that pre-hospital lactate levels have an impact. There's a huge amount of studies in the emergency department. Having an increased lactate in the emergency department is a bad sign. I will come back to that later because there are some nuance. There's very little information on lactate levels using on the general wards, to my surprise. But still, in the few studies that are available, if you find a patient on a general ward with an increased lactate, no good. In the OR, also very few studies, and most of them at the end of the OR, in the medium care or in the post-operating room care. Only a few studies, but the signal is still the same. In the ICU, of course, an abundance of literature telling you and proving you that having an increased lactate level or not decreasing lactate level is bad. A few studies at home, mostly with interventions like doing exercise at home and measuring lactate levels, but very few to hardly any study on prognostics or, let's say, seeking help when you have an increased lactate level, basically also because we don't have the monitors yet. A very important element of lactate is changes in lactate over time, and as Jean-Louis already almost 10 years ago showed, that if you do not change your lactate, that's a bad signal. And as you can see in green, if you decrease your lactate level, that's a good sign. And it doesn't tell you what to do if it doesn't change, it's just an observation. So it's an indicator whether your, let's say, therapy is effective. And that's not only in septic shock, that's basically in every kind of diagnosis the patient is admitted with. And so whatever your diagnosis, if you come to an ICU with an increased lactate level and nothing changes, the patient is in trouble and you should evaluate. That's why we did ultimately the study in the Netherlands where we targeted changes in lactate levels, decreases in lactate level, by adjusting therapy, and we show that with a p-value of 0.07, that the patients benefit. Still, a few years later, we said, lactate-guided resuscitation saves lives. We answered, we're not sure. And so we did a study, p-value 0.07, and still we were not sure whether it saves lives. And that's why we did the Andromeda 1 shock study. We compared capillary refill time, so peripheral perfusion guided, one of Harry Weil's important aspects of shock, to lactate levels. So basically compared what we did in the Netherlands and then added a capillary refill time study. And that's where the doubt came from. Because what we found, so we did 2 hours of resuscitation, either in the lactate group, trying to decrease lactate, or in the peripheral perfusion group, trying to normalize capillary refill time. And after 2 hours, we assessed. And we showed that if you had still abnormal capillary refill time, despite in which group you were, the mortality was basically the same and almost 50%. That's a bad signal. But when you were able to decrease the capillary refill time, so normalize capillary refill time, if you were in the lactate group with normal capillary refill time and you kept on chasing lactate levels, you basically ended up with a higher mortality compared to when you stopped using lactate levels. And so that's the hesitation we had when answering the question, does it save lives? You have to be careful, and you have to create context. And I think the context on using lactate is, do you have hypoperfusion? And we published in the 10 pitfalls a nice flow chart where you could define whether the patient still has characterizations of hypoperfusion and treat it. And I think that's the real good combination to use to create context, because the context is incredibly important. This is mortality with lactate levels on the x-axis going to more than 20, and comparing 2 of my practices up until last year. One of my practices was in Bellevue Hospital. 95% of the patient is not insured. A lot of these patients live on the street. They live on alcohol, they have HIV, they have diabetes, and take their insulin maybe twice a week instead of twice a day. And so a very poor community. And the mortality, as I said, in the lactate study, the control group, no survival when your lactate was more than 10. If you were admitted to Bellevue Hospital with a lactate more than 20, you had about 30% survival. And so my first question when I was called from the emergency room, we have a patient with a lactate of 15, I always asked, what's the name? Because if it was John or David, or we all knew these patients, there was no hurry. Give them some food, give them something to drink, and they will do fine. But if it was not one of these patients, and lactate was 15, you stopped doing what you do and you ran to the emergency room. So that's context. What's the future? I think the future will be continuous monitoring. We have these wearables now, something like the glucose monitor that can measure your lactate. A lot of development now, but of course, even more in these cases, creating the context will be very important, because you can end up with a lot of patients in your emergency room with increased lactate that have no real problem. And I think there artificial intelligence can have a big impact. So, a patient with an increased lactate level, even after 45 years of development in ICU, still has a huge problem. A patient not clearing his or her lactate is in real trouble. And the challenge for you as a practitioner is to create context. Thank you very much.
Thank you so much, Jan, for that really nice tribute to Max Harry Weil. Our last speaker I'll call up is Edward Schenck. He's coming to us from New York in the United States, and he's going to be speaking about pathways to mortality in critical illness.
All right. Thanks, everyone. Thanks so much. Wait a second. All right. Here's my talk today. So we're going to shift gears. First of all, I want to thank the conference organizers, Dr. Vincent and Dr. Taccone, for inviting me here, for the chair people for leading this session. This is going to be a little bit more theoretical, and bear with me as we go through some different contexts and as we talk about pathways to outcomes in critical illness. So here's my disclosures, nothing relevant to this talk today. And so let's talk a little bit about why our trials fail. This is from around 30 years ago by Roger Bone. And already the idea that when you're thinking about clinical trials in critical illness, there's this mix of inflammation and anti-inflammatory processes that are happening in real time that we are unable to account for at the bedside. And if you fast forward about a decade, this is a cottage industry of discussing why clinical trials in sepsis and critical illness rarely move the needle. This is from John Marshall out of Toronto, conceptually that even in preclinical models of clinical trials, that depending on the insult, this is an example of TNF inhibition in murine models, that depending on the insult, you can have differential response to your intervention. So not only is there heterogeneity within our populations, there's heterogeneity in terms of our response. And we are embracing this. On the left-hand side of the screen, you can see in ARDS, the latent class analyses that have been studied for over a decade now, looking at hyper and hypoinflammatory phenotypes. And also on the right-hand side, you see the UMAP plot from the alpha, beta, gamma subphenotypes for sepsis-related heterogeneity. And this is finally forthcoming where patients from kind of differentiated with a parsimonious model on hyper and hypoinflammatory will be tested prospectively to see whether or not medications such as simvastatin or baricitinib interact with this type of heterogeneity in terms of improving their outcomes. I want to take a step back and think about Kaplan-Meier curves. And the reason I want to do that is because a curve like this tells a story. And the story is complex. And complexity is what I want to bring our attention to. And so what do I mean by complexity? Is so that, this is a hypothetical homeostatic balance on the y-axis here, and we have time on the x-axis. And from a starting conditions that are relatively similar, you can see that there's a differential response to a resuscitative maneuver, to antibiotic therapy, et cetera, where you can have worsening homeostatic balance or improving. And as you move through time, there are innumerable opportunities for this to differentiate. And that you can have worsening that goes to improving, you can have improving that goes to worsening. And so how do we guide our patients through their pathway to their outcome? So instead of a homeostatic balance, we have SOFA on the y-axis here. And when we think about everything that we do trials on, they generally are trials that focus on the initial conditions. We study antibiotic optimization, we study vasoactive medication titration, we study volume resuscitation, the timing of intubation, et cetera. And then the patients move through their initial conditions, but things can go wrong. Or things can go right, and there's innumerable numbers of additional treatment decisions that have to be made, including deresuscitation, physical therapy, nutritional optimization, to finally get to our outcome that we desire, our discharge. But things can go wrong. Sometimes stochastic events can intercede, such as a gastrointestinal hemorrhage, a secondary infection, et cetera, and then the pathway through their homeostatic journey changes. Or with similar initial conditions, we do everything right. We do our antibiotic optimization, titration of volume resuscitation, vasoactive medication, but this is followed by kidney failure, liver failure, et cetera, leading to refractory multisystem organ failure and shock, and ultimately mortality. And so when we go back to our Kaplan-Meier curve, we can see that every point, or every decrement, every outcome, is actually a complex journey through a pathway to that outcome. And more often than not, we are focused on the initial conditions. So from a 30,000-foot view, I'm stealing work from Stephen Wolfram, who's a physicist who helped found the Santa Fe Institute for Complexity Science in the United States, is that at some level, almost all triumphs in theoretical science are based on finding ways to reduce the amount of computational work it takes to predict how a particular system will behave. You just need to find the rules of the system. However, if one has all the information one needs to work out how some systems will behave, it still takes some irreducible amount of computational work to predict its outcome. And so this is the concept of computational irreducibility. And what computational irreducibility implies is that there can be no way to predict how a system will behave except by going through almost as many steps of computation as the evolution of the system itself. So to put another way, there's essentially no better way to find out what a complex system will do than by explicitly tracing through each step in its evolution. So let's change gears here. A tale of two trials, I'll call it, acid suppression in the ICU. On the left-hand side of the screen is the primary outcome from the SUP-ICU trial published around a decade ago in the New England Journal. You can see placebo versus PPI inhibition did not change mortality in the ICU. And here is the mortality curve for the more recent revised trial in the New England Journal published last year, where you have an overlapping mortality signal for administration of PPI in the ICU. And the primary mortality outcome from the SUP-ICU trial, these are large multi-center trials with thousands of patients, is I want to draw your attention to the severity of illness score, the SAPS score, divided here by a selected threshold for high-risk patients versus low-risk patients. You can see that the mortality varies around the null there, and that in the lower mortality predicted group, that the PPI actually potentially improved outcomes, whereas in the higher predicted mortality group, the PPI potentially worsened outcomes. You can see that the PPI reliably did decrease bleeding, so overt and clinically important gastrointestinal bleeding in the SUP-ICU group. And also, there was no effect on secondary outcomes such as pneumonia, C. difficile infections, or acute myocardial ischemia. And then if you move over to the revised mortality outcomes, this was not their primary endpoint, but it broken down by severity of illness, this time not by SAP score, but by Apache 2 scores, you can see a similar differential treatment response, meaning that in the lower risk patients, the PPIs improved mortality, and the signal was neutral, but trending towards harm in the higher risk patients. However, the bleeding outcomes when stratified by Apache score actually favored a greater reduction in bleeding in higher risk populations by the Apache score. And additionally, secondary and tertiary outcomes did not show any signs of increased pneumonia, C. diff infections, et cetera. So this was combined by a meta-analysis that showed, yes, PPIs reduced bleeding in the ICU, mainly powered by the SUP-ICU and revised trials. However, in the mortality in higher risk groups, there was a signal that that PPI actually increased mortality. The top is the ratio of the relative risks, at the bottom is the actual event rates. And the meta-analysis did not show any increased risk of pneumonia or C. diff infection. And so this is taken from the editorial of this meta-analysis and of the revised clinical trial. When trial data suggests that an ounce of prevention may actually kill you, it cuts hard against the grain. And what are we supposed to do with this information? What is causing the increased cause of death? Is it interaction with platelet inhibition causing increasing stroke or MI? There's no signal for that, but potentially that's a known interaction with Plavix, et cetera. Is there an unknown interaction between bleeding events and prolonging critical care? Are we actually focusing more when people bleed and allowing them to live more? And I follow this up with, has this changed your practice? You know, in order to believe that the increased mortality in the higher risk patients, it requires a leap of faith because we don't know how it happened. We have to believe that the conditions of the experiment are relevant to our patients going forward, that it's stable over decades in time and place, and that the applied therapy will interact with complex intercurrent events in a similar way. So what do I mean by intercurrent events? So in the cardiology literature, there's a lot of anxiety and a lot of standardization about endpoint definitions. So this is an example of an FDA-related task force about distinguishing the difference between the cause of death and the mode of death, and the primary cause from the intervening causes of death. So let's be specific about this. The cause of death is the primary cause that, or underlying disease or injury that initiated the train of events resulting in death, such as a myocardial infarction or a sepsis or acute respiratory distress syndrome, et cetera. However, the mode of death is the clinical progression towards a fatal outcome that's often manifested by multiple intermediate steps. We are all well aware of these steps. And the mode of death is generally regarded as the physiologic derangement or biochemical disturbance produced by the cause of death. And so this brings us back to pathways. We have a patient with sepsis that might develop multisystem organ failure, and then there's a partial response to our supportive care. However, this results in prolonged mechanical ventilation, complicated by a gastrointestinal hemorrhage, and at some point in the future, withdrawal of care and mortality. Patient with a myocardial infarction can develop pulmonary edema, respiratory failure, delirium, complicated by a fall, neurologic injury, and then poor prognosis and withdrawal of care. And so have we captured this in our trials in critical care interventions more broadly? These are examples from the ARDS literature out of the University of Washington. Montgomery in the 1980s established the mode of death in acute respiratory failure related to ARDS was not refractory respiratory failure most of the time. A few decades later, also from the University of Washington, Renee Stapleton established that death in the more modern era was usually preceded by withdrawal of care and usually not due to refractory respiratory failure for ARDS patients. This is an example of their guidance. They looked at 9 different organ systems that could have severe injury or irreversible injury, from sepsis, cardiovascular disease, respiratory disease, CNS, et cetera, on down the line. This has been taken forward into more modern times, you know, out of the University of Michigan and University of California, San Francisco, where we confirm that death is preceded by withdrawal of care in our ARDS patients, or from 75 to 80% of the time. And more intriguingly, that the death interacts with upfront heterogeneity. And so what do I mean by that is, you know, the UCSF group has taken a look at their hyper and hypoinflammatory phenotypes that interact with potentially with treatment, and seen that the distribution of the main organ failure at the time, usually of withdrawal of care, interacted with the upfront heterogeneity, meaning that the hypoinflammatory group usually died of refractory respiratory failure or failure to wean from mechanical ventilation, whereas a hyperinflammatory group usually dies of refractory circulatory failure. And so the example of what these severe definitions used by these groups are is, you know, septic shock would mean hypotension on vasopressors and no surgical intervention. I'm not so sure that this is actually a refractory septic shock, but this was carried forward from the 1980s. Refractory respiratory failure includes profound hypoxemia on high FiO2 with maximal ventilatory support, or refractory acidosis. Cardiogenic shock was arrhythmia non-responsive to treatment, or cardiac dysfunction. And all of these imply that care can be withdrawn due to a potential prognosis. So challenges with this type of shoe leather epidemiology to understand what our pathways are is it's labor intensive, expensive, somewhat arbitrary. My decision about what organ is involved may not be followed by what your decision would be. It's not routinely done in our trials, and it's impossible to scale. So let's change gears again. This is the C3PO project led by Mass General. So this is over 500,000 patients who are treated at Mass General, established an EHR registry. This is going to be specifically for heart failure outcomes. And To address the question that a physician adjudication at scale is not feasible, they screened heart failure admissions within this cohort, about 2,000 patients with ICD-based diagnosis of heart failure in the first or second position. They manually adjudicated whether or not these admissions were indeed due to heart failure. And then they use publicly available transformer models. So transformer models are the architecture behind ChatGPT, Llama, et cetera, that where they can perform extremely well at natural language processing tasks. And then they were trained on the discharge summaries where the reinforcement learning was towards the cardiologist labels. Or not reinforcement learning, rather. And so what did they find is that compared to heart failure diagnosis codes alone, which only had about a 35% accuracy towards the cardiologist manually adjudicated diagnosis, is that when you add the natural language processing, you get up to about an 80% accuracy. There's the receiver operating characteristic. And then they confirmed this in a randomized clinical trial of influenza vaccine on whether that could change the frequency of heart failure admissions with the previously trained C3PO model based on chart extractions PDFs from the medical dossier. They saw that the accuracy for the model to predict heart failure admissions was about 87%, and the agreement with expert adjudication was about 0.69. However, when they trained the model further on fine-tuning it within the invested trial itself, their performance greatly improved. So the accuracy increased up to 93%. And the human, and the agreement from the model to the human was quite good and often resembled agreement between humans about these sorts of distinctions. And you fast forward into the future, off-the-shelf language models have improved at a rapid pace. And so this is an example out of Northwestern where free text inputs just being put through Llama 2 or a specially designed fast healthcare interoperability resource GPT can rapidly and with a high degree of fidelity interpret FHR resource findings, which are concepts such as complaints within the medical record. And this can be taken from free text without further adjudication. And so why is this important? Registry-based massive clinical trials are here to stay. This is an example of what's coming in the near future. This is MegaRocks out of the, led by the ANZIX group. This is going to be an N equals 40,000 clinical trial in which, with a distributed data network where most of the data is coming from EHRs. And so finally, I'll leave you with considerations. The causal path to outcomes is largely unexplored in critical illness at scale. These pathways potentially interact with baseline conditions. And large language models are adept at interpreting complex textual concepts and if there are appropriately labeled training data sets. So this implies that there's a lot of work to be done if we were to take advantage of this context. And so lastly, is mortality a useful primary endpoint in critical care trials? This was a provocative opinion piece a few years ago in Chess. I would say yes, but I want to inspire you to embrace not only upfront heterogeneity, but also pathway heterogeneity to our outcomes. And with that, I thank you very much.
Okay, thank you very much. I think it is time to close this opening session. I would like to first thank Professor Vincent and Professor Taccone for putting together, and the committee for putting together an exciting program. I would like to thank my co-chair and the speakers for sharing their insights. I think we've learned a number of important things. And of course, thank you for being with us here this morning. Enjoy the rest of the conference.